Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
This is part 2 of a conversation with Dr. Patel and Sam Clancy from Regional Brain Institute. Be sure and check out part 1 in our previous episode.
And I'd like to talk a little bit more about the launch process as it relates to the importance of engaging the community on this front and educating the community about what stroke program is, what services you're offering, the level of service you're going to be offering, and then involving things like the local nursing staff, the local medical staff, and even EMS agencies as part of that dialogue to shift. And we've talked about this on previous podcasts, right? But it really gets back to this sort of this mental this de facto knowledge that I'm either not going to go to the hospital because they're going to transfer me, or if I'm an EMS provider, I'm not going to take my patients to that hospital because I'm just going to have to retransfer them anyway. Yep. So I'm just going to bypass them. And so the only way to get around the bypass, whether it's patients direct or EMS, is you got to involve them in the discussions. What are your thoughts on that?
When it comes to stroke care, every minute counts. Every minute that goes by, a patient loses 2 million neurons, and those neurons don't come back. It is an irreversible change, and that's one of the reasons that stroke is a leading cause of disability and death across the United States, particularly in the states that we provide services. And so providing coverage through continuum of care and a broad variety of hospitals helps address and underscore the root behind your question, Shane. When you get down to it, to help through the onboarding process, we have a very robust checklist because we understand that many of the sites that we provide services to have never had to or never been prepared to retain a stroke or neurocritical care patient. And so we work through with them what's necessary from a physical location perspective, whether it's equipment or otherwise. We work through the software and access credentials. We go through the whole privileging and credentialing process. But very importantly, when we're engaging in the onboarding discussions, we have, I'll call it a binder, there's an electronic version, but a whole binder full of the policies and protocols as to how those stroke patients should be handled. That is gold standard level of care for an acute workflow for the stroke patients and otherwise. And then we provide the training for the on-site staff, initial training for them. But we do reach out to and communicate with local EMS and other facilities to help those hospitals that we're providing services to, EMS, that they now have expert concierge stroke care capable of taking care of patients that come in, and most importantly, retaining them to avoid the situation that you've described. We do the same thing with local hospitals to help try to attract patients to the hospitals that we provide services to achieve better patient outcomes so patients aren't being driven either on their own or through an EMS vehicle long distances.
Yeah, I think that's fantastic. And I know in a lot of our programs that we've launched with RBI, those efforts have gone very well. We've done a lot of grassroots campaigns for hospitals. We've even done collaborative on-site presentations in communities involving all the local leadership, EMS agencies, medical staff, et cetera. And it really does promote the word to get out, so to speak. And, in the smaller communities, word of mouth is huge. And it definitely has made a significant difference. We've seen in multiple instances an increase of ED volumes by 20 to 30%, which has been sustainable. And you think, gosh, so is it a great metric to increase ED volumes? But I think the important thing is people are actually coming to the hospital now because they're able to stay there as opposed to just driving by the hospital to go to another place. And to your point, if you're losing 2 million neurons a minute, driving an extra 45 minutes or an extra 10 minutes it's just a bad idea, right? Uh-huh. And to be able to drive to a hospital, to have Dr. Patel on screen waiting for you to help guide that care is it's just it's just unprecedented. I mean, and the fact is, people need to know that, and they're not going to know that unless you talk to them, unless you get the word out. So it's so important. It's part of the launch process.
I think on that EMS standpoint, there's a lot more training and protocols being put in place now to make life easier for them as well. There's certain scores that have been developed now that have like great sensitivity. There's the Cincinnati pre-hospital score, the race score that Brian Health uses, and there's these scores that they look at, whether there's drift, whether there's a facial palsy, gaze deviation, and automatically based on that score, just looking at 3-4 things on your physical exam, you call into the ER and say, hey, I think this is a stroke, or I think this patient has a large vessel occlusion, and automatically, everybody's brains are firing just by asking 3-4 questions to the patient. And I think that these scores with above 80% sensitivity and picking up stroke-like symptoms, I think simplifying that for emergency medical services who have to deal with so much on scene has kind of helped them feel a lot more comfortable as well before they say, okay, this is a stroke and we need to call it in.
Yeah, for sure. And I think, the other thing I've seen in these engagements with the EMS agencies too is they just, I got to tell you, in a lot of instances, most hospitals have not done a very good job of engaging EMS agencies. And I got to tell you, when they're involved in this and they feel like they're heard and they get to talk with, the providers or a provider, or they get to at least in the weeds on the program and what it has to offer and how to make their lives easier, it really makes a big difference in terms of their likelihood to bring you patients ongoing. We're going to switch gears here a little bit. I know that Sam, and Dr. Patel, we've talked a lot about the acute side of the equation and the maintaining that continuity onto the inpatient side and sort of that acute stay by having accessibility to the neurocritical care physician as well as neurology and neurologist. But then it comes down to discharge, and you're going to discharge the patient and sort of closing that gap in the full continuum of care. And how do we keep that patient locally for as many services as possible, which would include at the point of discharge, well, now who are you going to follow up with once you're discharged, right? And in a lot of these hospitals, and even some cases, the larger ones, are struggling to outfit their outpatient neurology programs. And so one of the areas I know that RBI has expanded on significantly here most recently has been on the outpatient side. And so maybe you could touch a little bit on the importance of ongoing outpatient care and the likelihood of the importance of patients seeking neurology support post-discharge after an event like this.
Absolutely. When it comes to post-discharge outpatient care, it's absolutely critical. Strokes are caused for a reason. There are a number of underlying things that could cause a stroke, whether it's hypertension, it could be obesity. In some instances, particularly with individuals who are of Native American, genetics come into play, and there's a predisposition there. But most of the things that cause stroke are addressable, but they need to be addressed through expert outpatient care. And so RBI has been expanding its services very aggressively in outpatient neuro services with a high focus on pre-stroke, post-stroke care. We provide services absolutely beyond that, including outpatient general neurology services, headache clinic, with a focus on movement disorders, multiple sclerosis, a whole number of things. But when it comes to the post-stroke care, if you don't address the underlying issues, you are very likely to have a recurrent stroke, and the strokes just stack up. And so what we've seen is that by providing the outpatient neurology services, we've been able to essentially cut off the recurrent stroke pattern at a number of the facilities that we've provided services, where it's really fascinating to be able to look at the data. And because RBI, the services that we provide to a certain site, that site becomes a magnet for stroke patients. And so things go up, and then they drop off. And at the time period where there's a corresponding increase in outpatient neurology and other neuro services down the road, there's a very positive correlation between increased outpatient neuro availability and a decrease in recurrent strokes. And so it's extraordinary from a data and statistical perspective. And most importantly, we've been able to see really positive impact for patients.
Yeah.
All right, and just on that note, Sam had mentioned something about outpatient clinics, but from our end, I think it provides a lot more comfort to say that our patient can follow up with an RBI clinic, because when we're discharging from the hospital, I think the first question we get by family members or patients are, what's going to happen now? Or, are they going to see somebody? Are they not going to see somebody? Like, where do we go from here? And, taking care of strokes in the hospital is probably only 50% of the job. The rest still needs to be done outpatient, whether that's a rehab, medication changes. So I think that provides a lot more comfort to say, hey, you know what, we're going to send your information to our clinic and you can follow up here. They'll call you. And generally we try to follow up in our stroke clinics between 2 to 3 weeks post-discharge. Secondly, I think when patients do have, strokes, cryptogenic strokes that, we don't really have a reason for, majority of the time, those patients have undiagnosed AFib flutter. And if we don't catch it in the hospital, we need a good method outpatient to make sure that that is continuously looked at, so that, because that changes management. And if we're going to give the patient the best possible chance to reduce their risk of having another stroke, then having a continuity of care with an RBI provider, I think that provides a lot more ease for the patient and their family.
Sure. So back on the point, you're suggesting 2 to 3 weeks roughly post-discharge follow-up with neurology. Is that right?
Yeah, we try to see everybody within 21 days that's post-stroke.
Yeah.
Especially, that's kind of the model we want to continue to try to set up, to try to see as many patients as we can, especially just strokes really within 21 days if we can.
Sure. And I got that it just really brings up the point that with no outpatient neuro, the likelihood of you getting in at a remote site for a neurological follow-up exam and within 21 days, I just got to think the odds aren't good to make that happen.
It's terrible.
Yeah.
The best facilities right now, 6 months is
Right.
fast.
Right.
One site that we provided services to, there is an 18-month backlog of outpatient neuro services. And it's not, if you've got an 18-month backlog, going to result in highest patient outcomes. And then you find yourself as a hospital in a position where you're getting dinged with financial penalties for readmission rates and recurrent strokes. And it creates challenges for length of stay. And so taking care of the entire continuum of care through this very patient-centered concierge approach is critical to distinguish patient outcomes.
For sure, and I'm excited to get into some of the data here and some of the metrics about that process here in just a minute with one of your facilities that's produced some amazing results in pretty short order, really. But I think one step before that, just to again, the full picture of this program that I think allows a lot of flexibility in the program is the ability to then add on things like EEG capabilities, both continuous EEG and other EEG reading capabilities to really expand the capabilities of the acute neurological program, as well as the ability for EMGs. And so I think that RBI has really taken this stance that it's how can we be essentially the complete neuro provider, for so to speak, for the particular entities. And so definitely come to appreciate that about the RBI team and their willingness to try and expand those different types of offerings to meet the needs of what we're hearing in the communities. Plus, I definitely think it helps from a continuity perspective to have the same team involved in that process as much as possible. The same goes for pulmonary critical care and the outpatient pulm strategy for our teams there. It really does help to have the same team involved.
Absolutely.
Well, hey, let's get into a little bit about the impact of the programs, and I want we take this 2 different angles. One would be, I'm interested, Dr. Patel, in the experience that you've had over the years in providing this type of care. What your take is from a local provider's perspective, and how the local ER providers, the local primary care providers, and your interactions with that local medical staff, and the confidence that you've built on that team because as you pointed out earlier, as this program, we are the consulting physician, we're not the attending. And so I'm interested in your thoughts on that. And then the second part of that question, then Sam would be getting into some of the data and the metrics on the most recent reports that came out here just last week that are fantastic. So Dr. Patel, interested in your thoughts on relationships with the local providers.
Yeah, I think, again, what eases a provider is, knowing that somebody's readily available. And I think providing them with that gives them a lot of ease. And secondly, a lot of the interactions I've had with a lot of the providers, whether it's small hospital, rural hospital, big hospital, it really is just about kind of having somebody that will thoroughly evaluate the patient, go over the plan, talk about kind of next steps. And I think once we do that and we constantly communicate, for example, if I'm seeing a patient at one of the hospitals via tele, we'll see them via the camera, and then majority of the time the ER provider's not in the room. So it's the nurse and the patient. And so we'll make sure that once we're done talking to the family, the patient, the nurse in the room, we'll just call the emergency room back, talk to the provider, and we'll say, hey, this is kind of what I saw on my exam, thoughts on thrombolytics or no thrombolytics, and let's admit or discharge a patient, and this is kind of the game plan. And once we go over that, I think there's been a lot of easy communications with the providers to say, okay, we feel very comfortable doing this. And secondly, I think that as we've done this more, one of the things that we've actually noticed a lot is we've increased awareness and knowledge to the local providers, where now we'll have patients and providers or providers call us where patients coming into the emergency room via emergency medical services who hasn't been labeled as a stroke. The ER provider or the hospitalist or whoever is seeing the patient at that hospital will go to the patient and say, oh, actually, you know what? I think this is a stroke. And I think that's just happened because over time we've kept more strokes at that hospital. So therefore now all the local providers know exactly what to look for, know how important a timeline is, and pick up the phone and call us right away and say, hey, you know what? I think this guy's or this lady or guy's having a stroke, and we could offer thrombolytic. Now that they've seen us do it more and they know what the criteria are and what we do, sometimes they even go ahead and order the scans before we've even seen the patient, because they know exactly, hey, this is what they're going to ask for. And I think that's where it's kind of really helped us now, in the sense that before at these facilities, it was difficult to pick up strokes or pick up a change, and then it's difficult for providers to emphasize on when the last known well was, which really is the most important thing for us. And now that they've picked that up a lot sooner, we're within the window to make a change there. So I think that's been a big impact on a lot of the rural hospitals that I've seen.
Yeah. I think if anything else, just having that expertise available in their ear, available every day, so to speak, really elevates their game in terms of, I was brought up to speed on the latest stroke scales and offerings here, 6 months ago in a CME class, but gosh, all of a sudden, boom, here it is right in front of me. What do I do with it? So I think it brings the local teams more inside the game and inside the game plan, if you will, as part of these programs. And I think it just gives them more local confidence. If anything else, it definitely gives them sort of a heightened sense of awareness of stroke in general and things to look for certain.
Right.
So,
and Shane, to that point, it's something we haven't even talked about yet because it's so ingrained in the identity of RBI. It's within our DNA. We're collaborators. We're program builders at heart. We are not drive-by consultants. So many people in the telemedicine space, it's one acute consult, it's drive-by, you never work with them again, and you're just trying to drip and ship a patient successfully. That's not us at all. We want to work with really only sites that are seeking collaboration. Our team is full of concierge physicians who are patient-centered and provider-centric, who really are just another member of the medical staff. We're not forcing upon any site certain equipment or efforts or requirements. We're logging into their electronic medical record system, their imaging system, just like another member of their team, as if we were on site. For the on-site providers, it feels almost as if we were there in the room with them as the consultant taking care of their patients. And at a time when healthcare is evolving and developing, what we're after is something that's pretty simple, and the simplicity in our approach actually is pretty innovative because it has achieved extraordinary outcomes for patients and very high satisfaction for the on-site staff.
On that note, Sam, I'd like to get into a little bit about, as we talk about the impact of the programs, the impact of your most recent data that emerged here last week and the amazing outcomes that you've seen as part of the program. I wouldn't mind you giving an overview of that.
Yeah, Shane, I'd love to talk about outcomes. We're very proud of them, and there's certainly work to continue to be done. But even within the last week, we've seen extraordinary outcomes. One of the hospitals that we provide services to, health systems we provide services to, it's one of the largest tribes within the United States, and we're very proud to be able to serve them and other historically overlooked and vulnerable patient populations. But here in particular, uh, we've been able to achieve extraordinary increase in stroke volume at this site, being able to increase stroke volume just within the last 4 years, a 4 year period, of almost 3x what it was previously. But it's not just about attracting patients to the facility. It's also about keeping those patients close to home when feasible and medically appropriate to do so. And at the same facility, as soon as our team started providing care, patient transfer numbers dropped off. They were transferring what was over 100 patients per year annualized. And as soon as we started providing care, we reduced that number sevenfold and have been able to successfully keep those low transfer numbers. And this site is in a rural area. And so if there are transfers, they're primarily for interventional procedures, whether it be through a neuroendovascular provider who's needing to actually be in the cath lab, pull out a blood clot, or a neurosurgical intervention. But being able to keep patients close to home and decreasing patient transfers is excellent for the patient, but those patient admissions to the hospital are also helpful for an economic perspective to the hospital, and so it ends up being a win-win from that perspective. But the door to needle times, the faster care that we've been able to provide and achieve have been incredible. This one facility door to needle times were high over an hour, which is not atypical of a facility like this, but we've been able to get that number down on average to very close to 30 minutes. For multiple years in a row, and that's gold standard stuff for any facility, particularly a facility that is not in a metropolitan area. Outpatient neurology volumes are up very impressively, and as I've already mentioned, there's been the tie between increase in outpatient neuro services resulting in fewer recurrent strokes within that patient population, which is incredible. We've been able to do all of this in a way that is very safe. Facilities we provide services, one of them that was tracking the data very closely, hemorrhagic conversion rates associated with thrombolytics, which many providers, especially who haven't been giving and administering thrombolytics, are nervous about. Our team has been able to achieve hemorrhagic conversion rates of 2.2% using TPA as a thrombolytic. And when the national average is 6%, so much lower than the national average in terms of safe care with a potentially challenging drug to be used. We've also been able to see improved patient outcomes, which is most important to us. Not just did we increase volume, decrease transfers, and check all the physician scorecards in terms of metrics, but we've been able to shorten length of stay for patients, and we've been able to help patients who came in with very complicated situations, and there are a number of metrics to measure, whether it's the National Institute of Health stroke scale scores or modified Rankin scores. There are a number of them, but patients are coming in very sick and complicated on admission, but they're being discharged with one of those stroke scores by 70%. 70 to 75% between intake and discharge. 84% of those patients were able to achieve a severity measure score of 0 to 3 at discharge, which is within normal range. And so patients are coming in very complicated, and we invite the complicated patients because we have high confidence in our team and our expertise, but we're able to send patients home with a normal score 84% of the time. And over 50% of the time, the score is reduced all the way to 0. So incredible outcomes there when you're looking at what could be something that leads to a very challenging disability for that individual for a long term. But the numbers are looking good. And the latest and most impressive data point that we've been able to reflect on most recently is at this site in particular, we've been able to reduce mortality rates, being able to compare the mortality rates for this patient population compared to mortality, death due to stroke rate across the state that facility is located in compared to national averages. And because it's a Native American facility that we provide services to, able to compare all races versus American Indian, Alaskan, Native patient populations using the CDC's data. We've been able to achieve a 37% reduction in stroke death rate for the patient population that this hospital serves, which is just incredible, especially when you look at the fact that we've increased stroke volume by over 2.5 times. We've been keeping more patients, many more patients. They're coming in sick, and we've been able to reduce the stroke death rate for the entire county by 37% is an extraordinary feat and a testament really to our frontline, entirely to our frontline providers, Dr. Patel, Dr. Wanahida, Dr. Suku, the list goes on and on, who are taking care of those patients.
Yeah, that's phenomenal numbers, and gosh, 37% reduction in mortality is pretty impressive. Despite the higher volumes that are pumped in there, just simply, and that kind of goes back to the original conversation earlier about once people know the service is available, you're going to start attracting people rather than them driving to elsewhere for care. So that's so kudos to you, Sam, Dr. Patel, and the entire RBI team on those numbers. That's fantastic data, and excited to continue to move that service out in an aggressive fashion. I know we have a lot of programs in the pipeline right now to launch and continue to provide this amazing care across the country. One more thing I'd like to discuss here is, which is a little bit of a spin too in terms of the normal program management. Sam, I kind of get back to your point earlier of how you're not really a drive-by consulting provider, or you're just driving for the one and done sort of thing, but you're really there. The interest is in building a program, right? And the interest is because you can't achieve the numbers that you just described by being a drive-by consultant. You're not going to have a stroke program beam into the ED to suck patients out of there to get potential interventions and build a program that's going to sustain those kind of numbers. It's just not going to happen. And so the only way to do that is to partner with a team that has your best interest in mind and has the desire to build a program and help the hospital really flourish in this environment. And that sort of comes down to another unique, innovative concept around service line management. And I'd like you to, and as I mentioned before, we do this service in both critical access hospitals and very large tertiary centers and various models across those large and small hospitals with significant success in both large and small facilities. The service line management is more geared for a little bit larger size facilities. So maybe you could touch on that a little bit and some of the dynamics there.
Yeah, I'd love to. You're exactly right, Shane. The service line management piece is in addition to the acute, subacute, and follow-up care that we provide, EEG, and all the other professional physician and provider services that we provide. And really what we're looking for when it comes to stroke program service line management is fit with the site and with our team. Everyone needs to be leaning in. There needs to be mutual alignment on the overall objectives. But the goal is to enhance that facility stroke, neurocritical care, and overall neuro programs, aiming to help that facility become the leader within their service area, increasing patient capture, patient census, decreasing transfer, all the key data points that we've been talking about. We work collaboratively with leadership from the facilities that we provide service line management to, focusing on quality metrics, establishing targets and different initiatives aimed to strengthen the overall quality. But we also help engage in strategy associated with outreach to the community, whether that's to EMS or surrounding facilities and other hospitals. But we want to ultimately implement a strategic plan to enhance the level and scope of that facility. And so we meet regularly with them, whether it's quarterly stroke leadership team meetings or more regular task force meetings with those facilities. We work with the service line management clients that we provide services to when it comes to stroke program certification enhancement. And so one of the facilities that we provide service to is a 56-bed hospital that was not in a position where they had any stroke designation by a national accreditation standard. That they did from a state perspective, but we helped them first achieve acute stroke ready metrics certification, and then helped them advance the primary stroke center certification. And we just actually Thursday and Friday of last week achieved incredible outcomes, essentially scored a 99% on the survey, which is great. And then we've worked with larger facilities, helped them achieve comprehensive, the highest level stroke center certification. And then we've got another hospital that really falls in between those two. But we're very proud of what it is that we've been able to achieve with the stroke program service line management. And when we work in collaboration with the leadership of those facilities, all the outcomes are achieved, the data metrics are achieved much faster in an accelerated fashion, and the outcomes are even better. And so we do provide the services that are just the telestroke or just discrete services, but if you want to maximize your capability, it's done through the strategic leadership involvement that comes with the service line management.
Yeah, that's perfect. I do know that the facilities that have engaged in that program have really benefited significantly from that, as well as the community and the outcomes associated with that program. And there again, it just gets back to really the notion of trying to build a comprehensive program as opposed to, telemedicine and virtual care has really evolved over the years. And it's evolved from the one-off, where 15 years ago, the only billed claims were really teleradiology things and psychiatry. That was it for a decade, really. To now really augmenting and building a full-blown comprehensive program with partners that can remotely support the entire program and build a model that really is sustainable for the local facility while bringing blue chip physicians to the table. And your physician crew is located in various parts of the country, and similar to all of our we have over 350 physicians, and they're located all over the country. And there's obviously pockets of physicians that have a lot of physicians in one particular location. But the flexibility in the remote models really lends itself to attract the exact right cultural fit to the organization, and it really does perpetuate ongoing success in articulating the value proposition for your programs, and really resonates with the local medical staff, because we have seen that, we've proven that out. And the only way we can continue to get care to our clients that are so desperately in need of these high quality services is to partner with fantastic partners like Regional Brain. So we again are exceedingly thankful and grateful for our relationship and partnership with RBI. And Dr. Patel, you and all the work that you do on a day-to-day basis on the front lines for our patients and your patients across the country. And Sam, for you and the administrative team support, and Dr. Wanahita, as always, who's puts up with my phone calls at all kinds of weird hours. We talk at weird hours, but although she blocks me now, so she probably won't talk to me anymore. But at any rate, we couldn't do it without you, and our patients and our clients and our communities are so grateful for you as well, and the great and fantastic work that you're doing moving forward. So, looking forward to ongoing activities with RBI and the continued flourishment of our partnership moving forward, and continue to provide great stroke care across the country. So can't thank you enough for that. And also to just appreciate your time today. I know that this has been a time well spent recording, right? I mean, this was spectacular. But again, can't thank you enough. Can't think enough.
No, yeah. Shane, thank you for letting us be a part of it. Really appreciate it. Thoroughly enjoyed this conversation, and continue to work together to hopefully continue to provide stroke care in a lot of rural areas around America, and just continue to increase awareness throughout.
Yeah, can't agree more. Grateful for sure.
And we're very grateful for Teledyne and for you, Shane, and Andy, and the leadership team, Dr. Bosser, Jill, and there are many others. But we've had a great relationship over a number of years, and we continue to go a very positive direction and make an impact, and that's what it's all about.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@TELEDIGMhealth.com. For more information or general inquiries, please visit teledynehealth.com.